Welcome to this lecture on glaucoma, part of the Basic and Clinical Science course series. In this session, we will be covering Chapter 2, Intraocular Pressure and Aqueous Humor Dynamics. In this section, we'll highlight the key physiological concepts behind intraocular pressure, or IOP. Aqueous humor production. This fluid is produced at a rate of 2 to 3 microliters per minute in awake individuals. This rate follows a diurnal pattern, meaning it's higher during the day and decreases by about 50% during sleep, also known as the nocturnal phase. Aqueous humor drains from the eye via two main routes, the trabecular meshwork, which is pressure-dependent, and the uveoscleral pathway, which is pressure-independent. Understanding these dynamics is essential for glaucoma management, as changes in production or drainage can significantly impact IOP. The Goldmann equation helps quantify IOP by incorporating four major parameters: aqueous production rate, uveoscleral outflow, outflow facility, Episcleral venous pressure. It's important to note that IOP distribution in the population tends to skew high, but glaucoma can occur at any IOP, even in patients with statistically normal pressure. Finally, remember that all tonometry methods have limitations. No tonometer can measure the true intracameral pressure directly and accurately in every patient. Each method comes with assumptions and possible sources of error. Aqueous humor is produced by the ciliary processes located in the pars plicata of the ciliary body. From there, it enters the posterior chamber, flows through the pupil, and moves into the anterior chamber. The production rate is approximately 2 to 3 microliters per minute during the daytime, or diurnally. This rate decreases by about 50% during sleep, reflecting a nocturnal reduction in aqueous production. The total volume of the anterior segment, meaning the combined space of the posterior and anterior chambers, is roughly 200 to 300 microliters. This volume turns over approximately every 100 minutes, making aqueous dynamics a continuously active and vital component in maintaining stable intraocular pressure. The ciliary body contains approximately 80 ciliary processes. Each process is lined by a double epithelial layer, an essential structure for aqueous humor production. The inner layer is made up of non-pigmented epithelium, which is metabolically active. These cells are responsible for secretion and are characterized by tight junctions, numerous mitochondria, and apical microvilli, all of which support their secretory function. The outer layer consists of pigmented epithelial cells, which contain melanin granules and relatively fewer organelles. These two epithelial layers are oriented apex to apex, facing each other. Blood supply to the ciliary processes comes from fenestrated capillaries within the ciliary stroma, which branch off the major arterial circle of the iris. Importantly, the tight junctions between the epithelial layers contribute to the formation of the blood-aqueous barrier, which helps regulate the passage of substances into the aqueous humor and maintains the immunoprivileged environment of the anterior chamber. There are three primary mechanisms through which aqueous humor enters the posterior chamber. The first and most significant is active secretion, which is pressure independent. This process requires energy and is mediated by enzymes such as carbonic anhydrase 2. Active secretion transports sodium, chloride, bicarbonate, and other unidentified ions across the non-pigmented epithelium into the posterior chamber. This mechanism accounts for the majority of aqueous production. The second mechanism is ultrafiltration, which is pressure dependent. It relies on a pressure gradient between intraocular pressure and capillary pressure, allowing fluid to passively move through fenestrated capillaries in the ciliary stroma. Finally, simple diffusion contributes a smaller portion of aqueous production. This is a passive process where ions move across cell membranes based on concentration and charge gradients. Together, these mechanisms maintain a steady and regulated flow of aqueous humor, crucial for intraocular pressure homeostasis. A key characteristic of aqueous humor is its unique composition, which differs significantly from plasma. One notable difference is the high level of ascorbate, or vitamin C, found in aqueous humor. In humans and other diurnal animals, the concentration of ascorbate is significantly higher than in plasma. The blood-aqueous barrier plays a crucial role in maintaining this distinct composition. It limits the entry of plasma proteins into the aqueous humor, resulting in an optically clear, nearly protein-free fluid. In fact, the aqueous humor contains only about 1/200th to 1/500th of the protein content found in plasma. The primary protein that is present is albumin, which accounts for approximately 50% of total protein content in the aqueous. As aqueous humor flows from the posterior chamber through the pupil and into the anterior chamber, its composition undergoes alteration. This occurs due to interactions across several ocular structures, including the hyaloid face of the vitreous, the surface of the lens, iris blood vessels, and the corneal endothelium. These changes are influenced by active transport processes and dilutional exchanges, further shaping the biochemical profile of the aqueous as it traverses the anterior segment. Several classes of medications work to suppress aqueous humor formation, each targeting a different molecular mechanism. First, carbonic anhydrase inhibitors, or CAIs, target carbonic anhydrase 2 in the non-pigmented ciliary epithelium. While the precise role of carbonic anhydrase in aqueous secretion is debated, it's believed to contribute bicarbonate ions for secretion, possibly helping with intracellular buffering or the supply of hydrogen ions. Next, we have beta-2 adrenergic receptor blockers. These block beta-2 receptors, which are highly expressed in the ciliary epithelium. By blocking these receptors, the medications reduce aqueous production by two main mechanisms: decreasing the efficiency of the sodium-potassium ATPase pump, and reducing the number of active pumps involved in secretion. Finally, alpha-2 adrenergic agonists are also used. These are believed to reduce aqueous humor production primarily by reducing ciliary body blood flow, possibly through a reduction in cyclic AMP levels. However, the exact mechanism remains not fully understood. Together, these drug classes provide pharmacologic strategies to manage elevated intraocular pressure in glaucoma by limiting aqueous humor production at its source. Aqueous humor exits the anterior chamber through two primary outflow pathways, each with distinct characteristics. The first is the trabecular meshwork outflow, which is the conventional pathway. This route is pressure sensitive, meaning that outflow increases as intraocular pressure rises. Aqueous humor passes through the trabecular meshwork into Schlemm's canal and ultimately drains into the Episcleral venous system. The second is the uveoscleral outflow, also referred to as the unconventional pathway. This route is pressure insensitive and does not respond significantly to changes in intraocular pressure. In this pathway, aqueous humor exits through the interstitial spaces of the ciliary muscle and is absorbed by the venous circulation in the suprachoroidal space. Together, these two mechanisms maintain intraocular pressure homeostasis and are important targets in glaucoma therapy. The trabecular meshwork outflow pathway is the primary route for aqueous humor drainage and is pressure dependent. The flow path begins at the trabecular meshwork, then continues through Schlemm's canal, into the collector channels, and then to the episcleral veins. From there, aqueous humor drains into the superior ophthalmic vein, or SOV, and ultimately reaches the cavernous sinus. Functionally, the trabecular meshwork behaves like a one-way valve, permitting bulk aqueous flow out of the eye while resisting reverse movement, helping to maintain intraocular pressure. This pathway is energy independent, meaning it doesn't require ATP for flow to occur. However, the cells of the trabecular meshwork are phagocytic, and their activity can increase in response to inflammation or laser therapy, helping to clear debris and maintain outflow facility. The trabecular meshwork, or TM, is organized into three distinct layers. The uveal meshwork, which lies closest to the anterior chamber and provides the most direct route for aqueous humor to reach deeper layers. The corneoscleral meshwork, consisting of sheet-like bands that create a sieve-like structure. The juxtacanalicular connective tissue, located adjacent to Schlemm's canal. This layer is the primary site of resistance to aqueous outflow and is especially important in the pathophysiology of elevated intraocular pressure. Each eye contains an estimated 200,000 to 300,000 trabecular meshwork cells. As we age, several key changes occur. The cell count decreases, reducing the TM's ability to maintain outflow. The basement membrane thickens, which can reduce fluid permeability. And as a result, outflow resistance increases, potentially contributing to elevated IOP and glaucoma development. These structural and cellular changes underscore the importance of early monitoring and intervention in at-risk populations. The uveoscleral outflow pathway is also referred to as the unconventional pathway and is pressure insensitive, meaning it remains relatively constant regardless of intraocular pressure. The pathway begins in the anterior chamber, where aqueous humor passes through the spaces between ciliary muscle bundles. From there, it moves into the supraciliary and suprachoroidal spaces. Once in the suprachoroidal space, aqueous humor has several potential exit routes. It may pass through the sclera or follow perivascular or perineural channels. It can be absorbed into vortex veins, which carry venous blood away from the eye, or it may be drained via lymphatic vessels, a route referred to as uveolymphatic drainage. Although it accounts for a smaller portion of total outflow compared to the trabecular pathway, uveoscleral outflow becomes especially relevant in pharmacologic management, as certain medications, like prostaglandin analogs, primarily enhance this route. The modified Goldmann equation models how intraocular pressure, or IOP, is determined by the balance of aqueous production and outflow. The formula is P0 equals F minus U, which is divided by C, and PV is added at the end. P0 is intraocular pressure. F is the rate of aqueous humor formation. U is the uveoscleral outflow. C is the outflow facility through the trabecular meshwork. PV is episcleral venous pressure. To solve the equation, only 4 out of the 5 variables need to be measured to calculate the fifth. A key clinical concept is that resistance, R, to outflow is the inverse of outflow facility, R equals 1 over C. In glaucoma, aqueous production, F, is often within normal limits, but outflow facility, C, is reduced, meaning resistance increases and IOP rises as a result. Normal outflow facility, C, typically ranges from 0.2 to 0.3 milliliters per minute millimeters Hg. Within this range, IOP remains relatively stable even with minor fluctuations in C. This graph visually represents the inverse relationship between intraocular pressure, IOP, and outflow facility, C. As shown here, when outflow facility is low, particularly below 0.1 microliters per mil per millimeter Hg, even small reductions in C can result in steep increases in IOP. This is especially relevant in glaucoma, where resistance to outflow through the trabecular meshwork increases and C decreases. However, once outflow facility rises above approximately 0.2 to 0.3 microliters per mil per millimeter Hg, the normal physiologic range, the curve begins to flatten. In this range, IOP becomes relatively stable and less sensitive to changes in C. The key takeaway is that small changes in outflow facility at the lower end of the scale can have a large impact on IOP, which is why many glaucoma therapies target improving outflow through the trabecular or uveoscleral pathways. Direct, non-invasive measurement of aqueous humor production is not currently possible. Instead, at steady state, it's assumed to equal the outflow rate. The most widely used method to estimate aqueous production is fluorophotometry. In this technique, fluorescein dye is instilled topically, and its dilution within the anterior chamber is monitored over time to calculate flow. Normal aqueous production in awake individuals ranges from 2 to 3 microliters per minute. This volume is turned over at a rate of approximately 1% per minute, and production decreases by about 50% during sleep, reflecting a diurnal pattern. Several physiologic factors influence production: integrity of the blood-aqueous barrier, blood flow to the ciliary body, neurohumoral regulation of the vascular and ciliary systems. Production may be decreased in several clinical scenarios, including trauma or intraocular inflammation, systemic medications such as general anesthetics or systemic hypotensives, topical aqueous suppressants, carotid occlusive disease, which compromises blood flow to the ciliary processes. Understanding these influences is essential for both diagnosing abnormalities and tailoring treatment strategies for patients with elevated or reduced IOP. Outflow facility, or C, in the Goldmann equation is the inverse of outflow resistance. R equals 1 over C. Normal outflow facility ranges between 0.22 and 0.30 microliters per minute per millimeter Hg. It decreases with age and can be impaired by ocular surgery, trauma, medications, or endocrine conditions. In glaucoma, especially with elevated intraocular pressure, outflow facility is typically reduced, even though aqueous production may be normal. In healthy eyes, around half of the resistance to outflow occurs in the trabecular meshwork. In primary open-angle glaucoma and ocular hypertension, pathology is most commonly localized in the juxtacanalicular tissue and the inner wall of Schlemm's canal. How to remember the juxtacanalicular region as the key site of resistance? Think of JCT equals jammed canal tissue. The juxtacanalicular tissue lies just before Schlemm's canal, and when it becomes dysfunctional or clogged, the canal gets jammed, causing resistance and elevated IOP. This region has the least structured extracellular matrix, making it the bottleneck in aqueous outflow. Hence, it's the key target in glaucoma pathophysiology and treatment. Let's now shift our focus to a historical method used to estimate outflow facility: tonography. Tonography is a technique used to measure aqueous humor outflow facility by artificially elevating intraocular pressure and monitoring how quickly it returns to baseline. This is done using a weighted Schaeutz tonometer or a pneumotonometer probe, which is placed on the cornea to temporarily increase IOP. The rate at which the pressure declines is then used to calculate outflow facility, reflecting how efficiently the eye is able to restore pressure equilibrium through aqueous outflow. However, tonography has several limitations. It is based on assumptions that may not always hold true, such as constant aqueous production and stable ocular rigidity and blood volume during the test. It is also prone to measurement errors, especially from poor fixation or eyelid squeezing. Because of these limitations, tonography is rarely used in clinical practice today. It is now primarily considered a research tool due to its limited accuracy and poor reproducibility. This slide covers the measurement and significance of episcleral venous pressure, or EVP, which is the pressure within the episcleral veins and represents the lowest possible intraocular pressure that the eye can achieve. The normal range for EVP is approximately 6 to 9 millimeters Hg. Several dynamic factors influence EVP. It varies with body position and systemic blood pressure. It can be elevated in conditions such as Sturge-Weber syndrome, carotid cavernous fistulas, cavernous sinus thrombosis, and thyroid eye disease. EVP can be lowered by topical Rho kinase inhibitors, which enhance aqueous outflow. EVP is measured using a technique called venomanometry, which is non-invasive. A flexible membrane is applied to the sclera, and external pressure is gradually increased until the episcleral vein collapses. That point indicates the EVP. This process is often assisted by video recording and image analysis software to improve accuracy. From a clinical standpoint, EVP is highly relevant because an increase in EVP leads to a proportional increase in IOP, roughly 1 millimeter Hg IOP for each 1 millimeter rise in EVP. Changes in EVP can also alter outflow through Schlemm's canal, affecting the Goldmann equation dynamics. As a result, observed changes in IOP may not match predicted values if EVP is abnormal. Uveoscleral outflow, often referred to as the unconventional pathway, cannot be measured directly using non-invasive methods. Instead, its rate is estimated by rearranging the Goldmann equation, once other parameters such as aqueous production, trabecular outflow, and episcleral venous pressure are known. Physiologically, this pathway accounts for up to 50% of total aqueous humor drainage. However, this contribution may be underestimated by invasive tracer techniques commonly used in research. The rate of uveoscleral outflow is not fixed and is influenced by several factors. It tends to decline with age and in glaucomatous eyes. Enhancing agents include cycloplegics, adrenergic agents, prostaglandin F2 alpha analogs, surgical interventions like suprachoroid stents or cyclodialysis clefts. In contrast, miotics are known to decrease uveoscleral outflow. Because many glaucoma therapies act specifically on this pathway, particularly prostaglandin analogs, understanding these modulators is critical for treatment selection and surgical planning. Intraocular pressure plays a central role in glaucoma, but interpreting it correctly requires context. In individuals of European ancestry, the average IOP is about 15.5 millimeters of mercury, with a standard deviation of 2.6. But this distribution isn't normal. It's non-Gaussian and skewed to the right, meaning that more people have pressures higher than average. To remember this, just think pressure rises to the right. The right skewed tail reflects those elevated IOP values that increase glaucoma risk. Genetics also play a role, influencing baseline IOP across individuals and populations. Traditionally, an IOP above 21 millimeters of mercury, about 2 standard deviations above the mean, has been used as a clinical threshold. But many patients with glaucoma have pressures within the so-called normal range, at or below 21. And conversely, many with pressures above 21 don't have glaucoma at all. This is why IOP alone isn't sufficient as a screening tool. It's not diagnostic by itself. The key clinical point is that intraocular pressure is a continuous risk factor. There's no strict normal or safe cutoff. Patients will often ask if their pressure is normal. The best answer is, it depends. The higher the IOP, the greater the risk of optic nerve damage. That's why all glaucoma treatments, regardless of starting pressure, are focused on lowering IOP to reduce that risk. Intraocular pressure can fluctuate based on a wide range of physiologic and environmental factors. These include the time of day, body position, respiration, exercise, and both systemic and topical medications. IOP tends to be lowest when the patient is seated with the neck in a vertical neutral position. It increases in the recumbent position, likely due to elevated episcleral venous pressure. Some individuals show an exaggerated rise in IOP when lying down, and this pattern has been linked to increased glaucoma risk. Substances can also affect pressure. Alcohol tends to cause a transient decrease. Cannabis may lower IOP slightly, but it's not clinically useful because of its short duration and associated systemic hypotension. Caffeine, despite common concern, does not significantly affect intraocular pressure. And age, on its own, has minimal impact in otherwise healthy individuals. The textbook also highlights common modifiers of IOP in a helpful summary table. Pressure tends to rise with elevated episcleral venous pressure, such as when lying down, holding breath, during Valsalva, intubation, or even wearing a tight collar. Rubbing the eyes or crying can also increase pressure, as can hormonal imbalances like thyroid disease and various drugs including corticosteroids, anticholinergics, LSD, and ketamine. On the other hand, IOP tends to fall with exercise, anesthetics, and pregnancy, as well as with substances like alcohol, heroin, and cannabis. Understanding these variations is important for interpreting IOP measurements in clinic and avoiding misclassification. Intraocular pressure naturally fluctuates throughout the day, with a typical variation of about 2 to 6 millimeters of mercury over a 24-hour period. Interestingly, peak IOP often occurs in the early morning, even though aqueous humor production decreases during sleep. This counterintuitive rise is mainly due to reduced outflow, both through conventional and uveoscleral pathways while we're lying down. That said, the amount of fluctuation varies significantly from person to person. Patients with higher average pressures tend to have wider swings in IOP throughout the day. There's some evidence that surgery may reduce these circadian fluctuations more effectively than medications. A useful clinical pearl here: if a patient is progressing despite having normal pressures during clinic hours, consider measuring IOP after hours. You might catch a pressure spike that explains the ongoing damage. As we mentioned in the previous slide, intraocular pressure can fluctuate significantly throughout the day. And these fluctuations aren't just noise. They've been linked to glaucoma progression, especially in patients whose average IOP appears low. These fluctuations tend to track with mean IOP, but they add an additional layer of risk that isn't always picked up during routine office hour measurements. And just like before, surgical intervention stands out, not only by lowering pressure, but by reducing the degree of IOP variability, even more so than medications. However, it's important to note that most of this evidence comes from retrospective studies. The specific thresholds or patterns of fluctuation that reliably predict progression remain uncertain. Now that we've discussed how intraocular pressure fluctuates and contributes to glaucoma progression, let's turn our attention to how we actually measure it in clinic. Tonometry refers to non-invasive measurement of IOP, and while it's a critical tool, it's not without limitations and potential sources of error. The gold standard is Goldmann applanation tonometry, which is based on the Imbert-Fick law. It works by flattening a 3.06 millimeter diameter area on the cornea and calculating the pressure based on the force required to do so. This method requires both fluorescent dye and a topical anesthetic and uses a split-image prism to align fluorescent Meyers until the semicircles just touch in the middle. That's your endpoint. A portable version of this device is the Perkins tonometer, which uses the same principles and is useful in situations where the patient can't sit at a slit lamp. However, several factors can introduce error. Inadequate fluorescent can obscure the Meyers, and variations in tear film thickness can skew readings. Thick tears may falsely elevate IOP, while thin tears may falsely lower it. Other pitfalls include astigmatism, corneal edema, which can give you falsely low readings, scarring, which give falsely high readings, or the use of soft contact lenses, which gives you falsely low readings. Astigmatism can cause elliptical Meyers, requiring either rotation of the prism or averaging two readings 90 degrees apart. Despite these limitations, applanation tonometry has advantages. It causes very little fluid displacement, minimizing any iatrogenic IOP elevation, and it's less affected by ocular rigidity than older indentation methods. Continuing from our discussion on applanation tonometry, let's now explore how central corneal thickness, or CCT, affects IOP measurements. Goldmann tonometry is most accurate when the cornea is around 520 microns thick. You can think of 520 as the Goldilocks zone, not too thick, not too thin, just right for reliable measurements. Now, when the cornea is thicker than this, it resists flattening, requiring more force. That leads to a falsely elevated IOP reading. A helpful way to remember this is, thick is tricky high. Thick corneas can trick us into thinking the pressure is higher than it actually is. Conversely, thinner corneas flatten too easily, leading to underestimation of IOP. We say thin is tricky low. This becomes especially important after keratorefractive surgeries like LASIK, which thin the cornea. These patients often have normal-appearing IOPs that are actually underestimated.
It's worth noting that we don't have a validated correction formula for corneal thickness because biomechanical properties vary between individuals. But even beyond measurement error, a thin cornea itself is an independent risk factor for glaucoma progression. So again, the key takeaways are 520 microns is the calibrated standard, and deviations, whether thicker or thinner, can mislead IOP interpretation. Just remember, more cushion, more pressure when it comes to thick corneas, and deflated cushion, deceptively low for thin ones. Let's move on to the next concept.
Now that we've reviewed how central corneal thickness affects Goldmann tonometry, let's talk about an alternative method, McKay-Marg tonometry. This technique uses an annular ring to flatten the cornea and measures the center pressure with a transducer. The IOP is recorded at the exact moment the central cornea just touches the ring, so it's all about that initial point of contact. McKay-Marg devices, like the TonoPen, are particularly useful in settings where traditional tonometry isn't ideal. These are great for patients with irregular corneas, such as those with scars or edema, or for supine patients where positioning can be challenging. That portability and flexibility comes with a trade-off. McKay-Marg tonometry tends to underestimate high intraocular pressures and overestimate low pressures. So just remember, it's convenient but not perfect. A handy way to keep it straight is to think TonoPen is good in a pinch, but pinch hits aren't always accurate. Let's keep going. Following our discussion on McKay-Marg and portable options like the TonoPen, let's now move on to another non-contact method, pneumotonometry. This technique uses a flexible silicone diaphragm with a constant airflow. It measures intraocular pressure by detecting how much air pressure is needed to close the gap between the diaphragm and the cornea. Pneumotonometry is especially helpful in tricky cases. It works well for patients with corneal scars, and it's even been used on keratoprosthesis patients, though using it on the sclera is not officially validated. It's also useful in supine or decubitus positions, where standard methods like Goldmann are hard to perform. And importantly, it allows for continuous IOP recording, which can be valuable for tracking pressure trends over time, not just snapshots. So in summary, when you need flexibility, literally and clinically, pneumotonometry is a solid tool in your arsenal. Continuing with alternative tonometry methods, let's now take a look at dynamic contour tonometry, or DCT. Unlike applanation-based techniques, DCT is a non-applanation contact tonometer. Its unique tip is specially designed to match the curvature of the cornea. It measures IOP based on the pressure in the tear film between the tip and the corneal surface, no flattening required. An added bonus is that it records not only the intraocular pressure, but also something called ocular pulse amplitude, or OPA. That's the difference between systolic and diastolic IOP, giving insight into ocular blood flow dynamics. Importantly, DCT is less affected by corneal thickness and corneal biomechanics, which makes it a more reliable option in eyes where these variables might otherwise skew measurements. Another method you may be familiar with is non-contact tonometry, commonly referred to as the air puff test. This technique measures the amount of air force needed to indent or flatten the cornea. Instead of making physical contact, it uses light reflection to determine when sufficient flattening has occurred to estimate intraocular pressure. One key limitation is that it tends to overestimate IOP, and the results can be quite variable between tests. Because of this, it's typically used in non-medical settings, like at public health screenings or optical shops, more for triage than for clinical decision-making. Now let's talk about a more advanced form of non-contact tonometry, the ocular response analyzer. Unlike the standard air puff, this device adjusts for corneal biomechanics, providing a more refined measurement. It gives us two key pieces of information. First, corneal compensated IOP, or IOPC, which has been found to correlate more strongly with glaucoma risk than traditional IOP measurements. Second, it measures corneal hysteresis, which reflects the cornea's ability to absorb and dissipate energy. Think of it as the difference between the inward and outward rebound pressure during the test. A lower corneal hysteresis is linked with a higher risk of glaucoma progression, making this measurement particularly useful in assessing patient risk beyond pressure alone. Next, we have rebound tonometry, which uses a small probe that lightly contacts the cornea and then rebounds back. It's quick, portable, and does not require any anesthesia, making it especially useful in settings where speed and patient comfort are priorities. It's particularly helpful for use in children and for home intraocular pressure monitoring, such as with the Eye Care Home device. However, keep in mind, rebound tonometry is strongly affected by central corneal thickness, or CCT, which can influence the accuracy of the IOP measurement. As we wrap up the discussion on tonometry techniques, it's essential to highlight infection control, given the close contact these devices have with the eye. Several pathogens, including HIV, hepatitis C, and adenovirus, can be transmitted through tears, so strict disinfection practices are a must. The best practice includes immediate disinfection of any reusable tips, ideally using sodium hypochlorite, or bleach, which has proven effectiveness against viruses. Alcohol wipes alone may not be sufficient, so they should not be relied on as the sole disinfectant. Whenever possible, disposable tips, like those used for Goldmann or Perkins tonometers, should be used to reduce the risk of transmission. And finally, always rinse and dry prisms thoroughly before reuse to avoid damaging the corneal epithelium. By following these protocols, we can ensure both patient safety and accurate IOP readings. Lastly, as we mentioned before, not all intraocular pressure measurements require devices. In situations where patients are uncooperative or equipment isn't available, clinicians may rely on tactile tension. This involves digital palpation of the globe, gently pressing on the closed eyelids to estimate pressure based on resistance. It's particularly useful when only large differences in IOP need to be assessed, or when a patient can't sit still or tolerate instrumentation. But keep in mind, the accuracy of this method is highly dependent on the clinician's experience. It's more of a quick screening tool than a precise measurement. Thanks for tuning in, and great job staying engaged. To consolidate your learning, we've provided a set of OKAP-style self-assessment questions following this slide. These cover everything we discussed, from aqueous dynamics to tonometry techniques and infection control. Take some time to work through them. They're designed to challenge you, reinforce key points, and prepare you for real-world clinical reasoning as well as your exams.